This program is brought to you by Emory University.
Welcome, everybody. Good morning. Welcome back to the beginning of Friday morning Fellows Conference for the 2022-2023 academic year. For those of you that are new to this conference, we will be having it almost every Friday morning from now until the end of May. Some weeks it'll be fellows presenting interesting clinical cases or clinical topics. The second to last Friday per month will usually be a journal club where two fellows will present a recent clinical trial, and we'll review and have discussion. And then usually the last Friday of the month will be M&M. So we'll go ahead and kick it off. Our speaker today is Dr. Sonali Kumar. As you can see on your screen, she is a fourth-year fellow as part of our clinical investigator track. She did her undergraduate and medical school studies at George Washington University, came to Emory for residency. She will be returning to the DMV next year to do an imaging year at Georgetown, advanced imaging. And as you can see, she's going to talk about an interesting case of acute aortic regurgitation. Sonali.
Great. Thank you, Dr. Williams, for that kind introduction. So I'm going to be speaking about a case on acute aortic regurgitation manifesting as cardiogenic shock. Okay. So I'll begin with the patient presentation. This was an 82-year-old female with a past medical history of aortic stenosis, status post bioprosthetic aortic valve placement. It was a 25 millimeter mitral flow valve in 2008 at Piedmont, which was complicated by severe bioprosthetic aortic stenosis, moderate aortic insufficiency, hypertension, hyperlipidemia, rheumatoid arthritis, who presented with an abrupt onset of dyspnea on exertion, orthopnea, malaise that were ongoing for 3 days, and nausea and vomiting ongoing for 1 day. Her home medications, she was on amlodipine, aspirin, a thiazide, metoprolol succinate 50 daily, methotrexate for her RA, some vitamins, and lovastatin 20 milligrams daily. Vitals, her heart rate was normal, around 83. Blood pressure was 142/51. She was sitting comfortably on room air. For her pertinent physical exam, regular rate and rhythm, she had a 3 out of 6 late peaking systolic murmur that was radiating to the carotids, best heard over the right upper sternal border. No visible JVD and no lower extremity edema. Her abdominal and neurological exams were unremarkable. Pertinent initial labs, so potassium of 4.4, magnesium 1.9, renal function was within normal limits. Her high sensitivity troponin was 423, BNP was elevated at 2063. A1C was 4.4%, and TSH was within normal limits. So her initial EKG showed sinus rhythm, left atrial enlargement, LVH with repole, and this ST depression in the inferior leads, and old lateral T-wave inversions. Chest X-ray was pertinent for pulmonary edema, and she had an old chronic left lower lobe consolidation. So the ED's plan was to diurese her with Lasix 80 IV for acute decompensated heart failure. They called me, I was on call for general cardiology at Midtown, and the plan was to admit her for IV diuresis. So shortly upon her arriving to the floor, she actually noted this improvement in her shortness of breath, but had persistent GI symptoms, mainly nausea, vomiting, and malaise. So we repeated her EKG, troponin, and her labs, and you can see here that it is significantly different from her prior EKGs. So all the changes that were seen previously look more amplified. The ST depressions in the inferior and the lateral leads are more profound. She also has ST elevation now in the anterior leads, and also has ST elevation in AVR. So at this point, again, she's reporting resolution of this shortness of breath, but the nausea and vomiting are getting worse. She's more hypotensive. Blood pressure has dropped to the 90s over 50s, still not tachycardic, and still sitting comfortably on room air. Her EKG, though, does look significantly different than prior. At this point, went in because the EKG had changed so dramatically. And I was worried mainly about ischemia. Seeing that ST elevation AVR, I was worried about an occluded left main or a high grade proximal LAD occlusion, but surprisingly, she did not have any regional wall motion abnormalities. Her EF actually appeared to be normal. So at this point, I called the interventional cardiologist on call, Dr. McDaniel, and because of the diffuse changes on her EKG, we had a very low suspicion for STEMI, and she was not emergently taken for a left heart cath. So I thought this case really highlighted the differential for ST elevation in AVR. So what should you think about when you see that? So tachydysarrhythmias, non-cardiac shock states, so septic shock, hemorrhagic shock, aortic dissection, PE. As far as ACS goes, which is what I felt like I was really anchoring on when I saw that. So per the ACC and AHA guideline for managing ST elevation with multi-lead ST depression and coexistent ST elevation AVR, so this has been seen in patients with left main or proximal LAD occlusion, so should definitely be on your differential. However, in a study of 847 STEMI activations, 99 patients had elevation AVR with this concomitant diffuse ST depression, as our patient had. And then of these 99, 80% had an emergent left heart cath, and acute thrombotic occlusion was found in only 10% of these patients. So you should definitely consider ACS when you see an EKG like that, but you do not want to anchor yourself on that diagnosis. So due to hypotension and concern for overdiuresis in this preload dependent patient with her EKG now showing this concern for global ischemia, her high sensitivity trope had risen to just above 1,000, we made the decision to give her a gentle fluid bolus back of 250 cc's, and she was started on heparin. PE, looking at an EKG like that and talking it over with Dr. McDaniel, it was on our differential. However, she was never really hypoxic. She wasn't tachypnic and wasn't tachycardic either. And shortly after she came to the floor from the ED, she unfortunately had an episode of vomiting and a witnessed aspiration event at the bedside with subsequent hypoxia and altered mental status. This was witnessed by the resident. She had a PEA arrest, required CPR ×2, was intubated, started on Levophed and Epi, and then transferred to the CCU for further management. So at this point, go back in for the second time because her clinical course had really deteriorated again. And luckily at that point, I also had the help of the echo techs, and this was what we saw. So her aortic valve now was even more abnormally functioning compared to prior. So she still had that moderate to severe stenosis, but there was now severe aortic regurgitation. On my bedside images, she just had severe wide open AI. Her aortic valve max velocity was 3.86 and the peak gradient was 59.6 with a mean gradient of 33. So the previous slide had a VTI measurement, and I just wanted to use that to make a point about the Doppler equation. So the Doppler equation gives the Doppler shift frequency, which is the difference between the emitted and the reflected ultrasound frequencies. And in this equation, V is the red blood cell or tissue velocity. Cosine theta is the cosine of the angle between the path of the ultrasound beam and that of the blood flow or tissue velocity. And then C is the average speed of ultrasound in soft tissue, which is 1540 meters per second. So this first figure on the top here basically shows a positive Doppler shift. So when you have a traveling wave of ultrasound hitting RBCs that are moving toward the transducer, the frequency of that reflected wave is increased above the emitted wave. And an important component of this equation is the cosine theta term. It's present in the numerator in equation 1. So as the angle between the axis of the beam and the direction of blood goes up, then cosine theta becomes less than 1, and your measured Doppler shift frequency is decreased. So that calculated velocity will also be decreased. As that angle goes up, the cosine theta goes down, as noted by the second table. And the ultrasound machine assumes that theta is 0 degrees. The cosine of 0 is 1, as we all remember from high school physics. So cosine theta drops out of the equation in equation 2. And in order to accurately measure the peak velocities of blood flow, the beam should be oriented as close as possible to your direction of flow. So an angle between the beam and the axis of blood flow of up to 20 degrees is considered generally acceptable, because at this point, at this angle, you only have an error of 6% in your measurement of peak blood flow velocity. And the ultrasound machines actually do have an angle correction function, and the cursor could actually be directed along the apparent axis of blood flow. But as we know, blood flows in 3 dimensions. So even if you do this, the path cannot really be accurately approximated with a 2D angle correct cursor. So ASC, or the American Society of Echocardiography, actually does not recommend correcting for this angle. The point of this is to say that a major clinical ramification of this equation is that impact of the cosine theta term, which can influence your ability to really accurately measure peak blood flow velocities. And as an example, in the third figure at the bottom, the peak velocity of TR, or tricuspid regurgitation, is underestimated when the dashed line, the Doppler cursor, is not aligned with the axis, which is given by the arrow of regurgitant flow. Okay, so a point about the valve that our patient had. So this is one of the mitral flow valve is one of the most frequently used bioprosthetic valves, with over 100,000 implanted worldwide. So it's bovine pericardium that's mounted externally around the stent. And this is supposed to maximize flow relative to the stent. The valve is placed in a supraannular position compared to an intraannular position that's seen in some of the other bioprosthetic valves. And these characteristics are supposed to allow for better hemodynamics, especially in those like our patient who had a small aortic annulus. And for that reason, it's considered an ideal valve for patients who have a small root, aortic root. So now we're in the CCU. Her pressor requirement initially, surprisingly, was noted to decrease, and she was trying to communicate with the team and was responding to commands and was interacting with family members as well. So consulted structural and CT surgery, who both knew this patient very well and were following her as an outpatient for several years. So my question was why the TAVR had not been pursued earlier. And this was because she had a high-risk anatomy and there was concern for intraprocedural ACS due to low coronary takeoff. So she was deemed to be a high-risk candidate for a valve-in-valve or a surgical redo valve replacement. And so that morning, consulted structural cardiology. Dr. Deva Reddy was the attending. We talked her case over, and given the patient's minimal tolerance for volume removal and ongoing cardiogenic shock, structural cardiology essentially recommended supportive care and a palliative consult. So I hope all the videos play here, but the first picture on the left shows how close that valve-in-valve TAVR would be to the coronary. You can see the left main taking off right there. So this, I think, really highlights why the coronary obstruction risk would be so high. And then this video, which I hope plays, shows, which shows how calcified the her prosthetic valve really was. Okay, so during the course of rounds, she arrested 3 times, and each time it was pulsus VT. She had progressively worsening diastolic blood pressure on the A line. Dr. Cutchins was the attending, and we had multiple discussions with family at the bedside, consulted palliative, and basically, said that future resuscitation events were going to be futile, and the patient ultimately passed. So she was an example of structural valve degeneration. So 40% of the time, these valves stenose, 30% of the time you can have regurgitation, and about a third of the time you can have a combination of stenosis and regurgitation. There are lots of definitions out there on structural valve degeneration. There is not a consensus about it, but I think that the one that's probably most relevant to us is, well, what is clinically relevant? And that is an increase in the mean transvalvular gradient by greater than 20, with a concomitant decrease in the EUA by greater than 0.6 during follow-up, leading to severe AS by current guidelines, or a new onset or increase in the grade of the intraprosthetic regurgitation, leading to moderate to severe or severe AI. So how does this happen? Well, it's multifactorial. You have calcification and leaflet degradation leading to stenosis or tear, leading to regurgitation. And the bovine pericardial valves have a greater propensity to develop stenosis, and the porcine have a greater propensity for regurgitation. The bioprosthetic leaflets are fixed in a glutaraldehyde to cross-link and mask antigens and avoid immune system rejection. This is supposed to make them immunologically inert. And free aldehyde groups resulting from treatment, along with phospholipids and calcium, leads to passive calcification. So this combination of hypercalcemia, hyperphosphatemia, and increased leaflet mechanical stress leads to mineralization, thickening, and disruption of the valve leaflet tissues. So this was a table on studies of how durable these surgical prosthetic valves are. Interestingly, our patient's valve was also on it, which is why I included this slide. This was a study in 2008. They looked at 1,513 patients with a mitral flow valve, and 4.2% of those required reintervention for some sort of structural valve degeneration. So the predictors of structural valve degeneration can be divided in 3 groups. You have factors that are directly related to the patient, and then there's your standard cardiovascular comorbid conditions, and then factors relative to the valve. In the factors that are directly related to the patient, the age at the time of implant is one of the most important factors that determine durability. So the rate of SVD at 10-year follow-up is less than 10% in elderly patients, but in patients who have it implanted earlier, younger patients, it can rise to 20 to 30% when they're under 40 years of age. So the management of bioprosthetic valve degeneration, the convention has been redo surgery, but this is associated with increased morbidity and mortality. A significant number of our patients refuse redo surgery. So the guidelines currently recommend valve-in-valve procedures for high-risk patients with aortic bioprosthetic dysfunction. So some aspects of these valve-in-valve procedures differ from our conventional TAVR procedures. So amongst other things, you have a higher risk for high residual gradients and coronary obstruction, lower risk for paravalvular leaks, and permanent pacemaker implantation. So there's not a lot of data on late outcomes following valve-in-valve procedures. The mortality rate of about 15% has been reported at 1-year follow-up. And the factors that we think about that are associated with this increased mortality are implantation of smaller surgical valves, stenosis as the main mechanism of valve dysfunction, and use of a transapical approach. So I feel like whenever I see these diagrams, they make everything seem so straightforward. Options are redo surgery, valve-in-valve TAVR, but I think like in our patient's case, there's a number of risk factors that can contribute that make this decision not as straightforward as is taught or as we see in the guidelines or papers. So definitely need to consider the whole picture of the patient and consider, the real risk, like our patient had, of complications during the procedure. Okay, so now we'll move on to part 2 of this talk and talk about how we evaluate aortic regurgitation. We'll go through the physical exam findings and talk about differences in acute versus chronic, talk about hemodynamics in acute versus chronic, mechanism and etiology, the echo qualitative assessment and quantitative assessment, and then a brief guideline review. Okay, so aortic regurgitation is different from a physical exam standpoint in acute versus chronic. So the diastolic murmur in acute tends to be soft and early. In chronic, it's a holodiastolic decrescendo murmur. The S1 is soft, tends to be soft in acute, and we'll talk about why that is later, and normal or diminished in chronic. The S2 has a loud P2 component in acute and is normal and chronic. In acute, these patients are oftentimes in shock or an overt clinical heart failure. So an S3 may be present and may be absent in chronic. And then briefly about the hemodynamics. So the cardiac output in acute, these patients are usually very sick, is decreased, is normal in chronic. The pulse pressure can be normal or decreased in acute and increased in chronic. Systolic pressure can be decreased in acute and increased in chronic. The EDP is severely increased in acute and normal in chronic, and the LV size is normal in acute and increased in chronic. So I did want to make a point. So the premature mitral valve closure is what's responsible for the softness or the absence of S1, because the mitral valve is closed at the beginning of left ventricular systole. A short early diastolic murmur and a short mid diastolic murmur terminating with a soft premature mitral valve closure sound can create a palpable summation gallop. And I did want to can't talk about AI without talking about the Austin Flint murmur. So there's no consensus about the cause of the sound that we auscultate as the Austin Flint murmur. He described his namesake murmur in 1862 in these very poetic words that I'll let everybody look at on their own. But this murmur is a low-pitched mid to late diastolic rumble that's heard best at the apex and is associated with severe AI. So like I said, there's no consensus on what leads to this sound. We do know that it's not affected by premature mitral valve closure. So it could be due to the regurgitant jet alone. It could be due to abutment of the AI jet against the LV epicardium, or the regurgitant jet directing at the anterior mitral valve leaflet, and you get this, what's described as shuttering of the anterior mitral valve leaflet, and then you get these subsequent shock waves that distort your regurgitant AI jet. And then this all is said to cause this familiar heart sound that we all hear as the Austin Flint murmur. Okay, so moving on to the hemodynamics of acute versus chronic AI, and the way that I like to think about it is that you have this innocent, unsuspecting left ventricle. So in acute severe AI, there's this sudden, excessive, massive volume overload on a left ventricle that's not prepared for it. So it's normal in size. So in figure A, you can see there's this dramatic rise in the LV diastolic pressure that can approach or even equal the aortic diastolic pressure. So because the left ventricle pressure exceeds the left atrial pressure during diastole, the mitral valve will appropriately or prematurely close before the onset of the next systole. And this is beneficial so that the high left ventricle diastolic pressure isn't transmitted back to the pulmonary venous system. So this is what is supposed to prevent pulmonary edema and overt clinical left-sided heart failure. However, this protection that is given by this closed mitral valve is lost when your ventricular atrial gradient keeps rising, and then the mitral valve will open in late diastole and you'll get diastolic MR. So MR in acute AR can actually occur in diastole or systole when the left ventricle diastolic pressure exceeds the left atrial pressure. And it's probably due to the persistence of that VA or ventriculo-atrial gradient due to the extension of the high LV diastolic pressure level during the isovolemic contraction period and early systole that leads to early systolic MR. So MR is supposed to be effective in lowering the LV diastolic pressure acutely because that left atrium serves as a reservoir of sorts for the blood that's regurgitated back from the aorta to the LV. But eventually, if this goes on for long enough, the left atrial pressure will rise even more, leading to pulmonary edema, circulatory failure, and shock. So in acute AI, like mentioned earlier, you have this elevated LV-EDP in a normal sized LV, and you have this dramatic near equalization of the LV and aortic and diastolic pressures. So acute AI can be complicated by coronary ischemia and may explain why we saw some of that ST elevation and worsening global ischemia pattern on the previous EKG, because the decreased diastolic flow decreases your myocardial perfusion. And then the elevated LV-EDP and tachycardia can increase myocardial oxygen demand. Chronic AI has a completely different physiology. In chronic, your LV has time. It has time to remodel, it has time to dilate, it has time to adapt. The stroke volume can increase to maintain forward flow, can have a more widened pulse pressure, and a low diastolic BP. Okay, so now moving on to the 2D echo assessment of AI. And I'll begin by talking about the classic mechanisms that we talk about. So type 1 is normal cusp motion with aortic dilation or cusp perforation. Type 2 is cusp prolapse, and type 3 is cusp restriction. This list is not meant to be exhaustive, but just things you should think about, etiologies, bicuspid aortic valves, rheumatic heart disease, calcific degeneration, infective endocarditis, idiopathic aortic dilatation, myxomatous degeneration, dissection, syphilis, the list goes on. So I feel like this might be beneficial to the first years. It's really important to note exactly where what you're talking about when you mention that the aorta is dilated, for example. A lot of these nuances with anatomy and terminology can be important for our patients that subsequently need to have intervention. So just a brief anatomy review. So we're looking at in figure A, we're looking at the peristernal long axis view that shows the measurements of the dimensions of the aortic annulus given by A. B is the aortic sinus, and C is the proximal ascending aorta. In figure B, you're looking at the suprasternal view, and the RPA indicates the right pulmonary artery. Okay, so echo evaluation of acute AI. So this is a color Doppler that shows that the aortic regurgitation jet width over the LVOT tract approaches close to 100%, like it did in our patient with a vena contractor of over 2. So this is showing very steep pressure half times, which can be seen in acute AI. And so a word about the evaluation of the mitral valve during severe AI. So premature mitral valve closure is present when the AI is thought to be acute and severe. And in figure G, you can see that's best demonstrated by M-mode echo with simultaneous EKG going. So premature closure of the mitral valve is specific and sensitive for acute AI. And the extent of it has actually been correlated to the degree in your rise of LV diastolic pressure. So in a normal situation, the mitral valve does not close until shortly after the onset of contraction of the left ventricle. So leaflet closure of the mitral valve occurs about 40 milliseconds after the onset of the QRS complex. Premature closure is mild or grade 1 when coaptation of the anterior and posterior mitral leaflets occur at or before the QRS. So for example, up to 50 milliseconds before the Q wave, but after the P wave. The premature mitral valve closure is marked or grade 2 when it closes very early, up to 200 milliseconds before the Q wave. These patients with grade 2, when compared to grade 1, have extreme elevations in LV diastolic pressures, and they're more likely to be the ones that you see that are very sick, in shock. They're really only marginally compensated. Unfortunately, I don't think our patient had great examples of this, but I just wanted to show in figure E, you can see an example of it's ECG gated, an example of diastolic MR. In F, you can see systolic MR, and then figure G we already talked about. In H, you can see both diastolic and systolic. So this is an example of holodiastolic flow reversal, which can be seen in acute severe AI. Okay, so part 3 of this talk is on the echo qualitative and quantitative assessment of AI. Okay, so we will talk about vena contracta, jet height, flow convergence. Okay, so like Dr. Thames likes to tell all of us, garbage in is garbage out. So how you measure all of these parameters is very important, and it can pretty dramatically affect your measurements. So for the jet width, you want to measure the color Doppler jet width and compare it to the LVOT width in the parasternal long or in the parasternal short. You want to zoom in the long axis and align the jet to optimize the vena contracta. And this could be different from when you do the PISA measurement. You want to measure the jet, which is given by these red arrows in the LVOT, within 1 centimeter of the vena contracta, and then measure the LVOT as well. This can be overestimated in apical views, but the takeaway is that a mild AI jet width is less than 25% of the LVOT, and severe is greater than or equal to 65%. You don't want to use the length of the jet to assess severity. So the advantages of this method are that it's simple and fast. Disadvantages, so you can underestimate your degree of AI in eccentric jets and overestimate it in central jets, because the jet can expand unpredictably below the orifice, which you can't really see. And it can be affected by the size of the LVOT. So proximal flow convergence, again, align direction of flow with the insonation beam. You want to zoom in and change the baseline of your Nyquist limit to be in direction of the jet. You want to measure this radius, which is given by this white arrow from the point of color aliasing to the vena contracta. The advantages of this are that it's quick. Disadvantages, multiple jets, having a constrained jet in the aortic wall, non-hemispheric shape, and then timing and early diastole. So this is a more qualitative parameter, the density of the regurgitant jet. Again, theme you'll see again and again. You want to make sure the beam is aligned with the flow and adjust your gain if need be. The density of the signal can be a sign of severity. So if it's more faint, it's consistent with mild. If it's more dense, more consistent with severe. So this is also a simple, pretty easy thing to do. However, the disadvantages is that while it's easy, it's qualitative, and perfectly central jets can be denser than eccentric jets of higher severity. And so you can have overlap of moderate and severe AI. So for jet deceleration time, again, align the beam with the flow. It's best from your apical windows. And for eccentric jets, you want to use the parasternal window and use color Doppler for help if need be. For mild AR, it's over 500. Moderate is 500 to 200, and severe is less than 200 milliseconds. This is simple. It's a specific sign of pressure relation between the aorta and the LV. The disadvantages of this, it's qualitative again, and not having correct alignment of the beam can lead to a lower pressure half time. And factors that can modify your LV aortic pressure gradient will also modify your pressure half time. So if you have a short pressure half time, it could mean that you have significant AI or that you just have high LV filling pressures. So holodiastolic flow reversal, align the beam with the flow, and you want to obtain the pulse wave Doppler in suprasternal or the subcostal views in either the descending thoracic aorta or the abdominal aorta, respectively. This obviously needs to be ECG gated, and it can be very prominent in severe AI. So the advantages of this is that it's simple, it's more specific if it's seen in the abdominal aorta. So disadvantages, it's not as reliable in our older patients because it depends on compliance. And brief velocity reversal can be seen in normal and can be seen in other conditions. You obviously have to correlate with what is clinically happening with your patient. So now we'll talk about quantitative Doppler-based assessment. Vena contracta, I think, sort of falls into both qualitative and quantitative, so I called it semi-quantitative. We'll talk about regurgitant volume, regurgitant fraction, the effective regurgitant orifice area, and the proximal isovelocity surface area. So the vena contracta, you want to be in the long axis in a zoomed in view and measure the narrowest jet diameter that's at or just apical to the valve, and measure the diameter of the regurgitant orifice. So in mild, the vena contracta is less than 0.3, and in severe, greater than 0.6. The advantages of this, it's a surrogate for the regurgitant orifice size, and it can be used, unlike some of the previous parameters we talked about, when you have eccentric jets. It's independent of the flow rate and driving pressure, and it's less dependent on technical factors, and can help you identify mild or severe pretty well. So disadvantages of this, so the presence of multiple jets, having bicuspid valves, you have to be able to see a convergence zone, and the direction of the jet can really influence its appearance. So the proximal isovelocity surface area, or PISA measurement. So this is based on a concept of fluid dynamics. You have these hemispheric assumptions of flow convergence for the calculation of the flow rate and regurgitant volumes. The flow velocity increases as you approach this circular opening, and the surface area of the blood moving back from the aorta toward the closed aortic valve at the given aliasing velocity is your PISA measurement. It looks like a hemisphere in 2D images, and the radius of the PISA can be used to calculate the diameter of the orifice, which can ultimately be used to calculate your area of regurgitation. So the radius is measured from the surface of the hemisphere to the narrowest segment of the Doppler beam, which is located within the orifice. So for this, you want to use a zoomed apical 3 or 5 chamber view. Again, align the beam with flow and lower the color Doppler baseline in direction of the jet, and look for the hemispheric shape to guide your best lower Nyquist limit. So the continuous wave of the regurgitant jet for peak velocity and VTI. And the advantages of this is that you can quickly assess for EROA using this measurement and regurgitant volume, but it's limited when the aortic valve is calcified, when you have multiple jets, eccentric jets, and a small error in the radius measurement can have disastrous implications on your EROA measurement. So we will go through an example of this. And so the EROA is given by the PISA times the aliasing velocity over your Vmax of the aortic regurgitant jet. It's also given by the regurgitant volume over the AR jet VTI. So this is all guided by the principles of the continuity equation. Your flow proximally needs to be equal to your flow distally. A1V1 is equal to A2V2. So we use 2 pi r squared and multiply that by the aliasing velocity, and that's supposed to be equal to the EROA times the jet velocity. So this is an example. So using 25.1 for your aliasing velocity, which is equal to the EROA over the peak AI times the peak AI velocity. And if you divide 116.6 by 525, you get 0.22 for your EROA, which is consistent with the moderate AI. So this is a calculation for regurgitant volume, which is equal to the EROA times the VTI AI. In this case, from the previous slide, we know that the EROA was 0.22. we multiply that by 294 and we get 65 cc's. And the cutoffs, so that would fall in the severe range. So mild is less than 30, mild to moderate is 30 to 44, moderate 45 to 59, and severe is greater than or equal to 60. So the regurgitant fraction is given by the regurgitant volume over the total stroke volume times 100. In mild, it's less than 30%, and severe greater than or equal to 50%. This is a very busy slide, and I included it because the point I wanted to make was that usually when we look at these echoes, we're really good about using these qualitative parameters that we talked about, and it can be very difficult to do the quantitative methods. And the place where I find them useful is when you're getting kind of intermediate values. You don't really know whether you're moderate or severe, or you're mild or moderate. So you can use these quantitative methods to refine your assessment. Okay, so this is just a table that I felt like was high yield for us as fellows to really know what these cutoffs are. So we'll just review. So for mild, the color Doppler jet width is less than 25% of the LVOT, and in severe, it's greater than 65%. You can have very little flow convergence in mild, but large in severe. The density of the jet is faint in mild, but dense in severe. So high pressure half time in mild, over 500, less than 200 in severe. You can have brief early diastolic reversal in mild AI, but it's very prominent, as we saw, for severe. For the quantitative parameters, less than 0.3 for the vena contracta for mild and greater than 0.6 for severe. The regurgitant orifice area is less than 0.1 for mild and greater than or equal to 0.3 for severe. Less than 30 for the regurgitant volume for mild and greater than or equal to 60 for severe. The fraction is less than 30% for mild and greater than or equal to 50 for severe. And like we remember from the hemodynamics portion of this talk, so in severe AI, you have the presence of LV enlargement, especially when it's chronic. So went through the surface echo parameters, but when are those not adequate? When do you consider, doing a TE or CMR? So one is the most obvious, when you don't have great images, or you don't have a lot of confidence in your Doppler-derived parameters due to having eccentric jets, multiple jets. And like we talked about, small errors in the diameter measurement can lead to very large errors in the EROA measurement, or you're having discordance between the quantitative and qualitative measurements. So very brief guideline review. If you have the severe parameters that we just talked about, and the patient has symptomatic AI, it is a class 1 indication to replace the aortic valve. However, if they're asymptomatic and their EF is less than or equal to 55%, or they need some other cardiac surgery, that's also class 1. And then if their EF is greater than 55%, or their LVN systolic diameter is greater than 50, index greater than 25, that's class 2A. And that's all I had. Thank you to Dr. Shi for reviewing the scans with me, the CT scans. Dr. Cutchins was the attending in the unit when we were taking care of this lady as she was coding just multiple times in the morning during rounds. Dr. McDaniel was the interventionalist on call who I spoke to. Dr. Wells was also on call. Dr. They've already followed this patient in clinic. And thank you to Dr. Thames for guiding me with the echo slides in this talk. And that's all I have.
Thank you, Sonali. Very good and comprehensive review. Had, one thing, regurgitation is tough, and I thought you did a very good job of sort of reviewing the differences sort of in physical exam and echo between acute and chronic. A lot of the echo stuff you discussed obviously was more sort of for evaluating chronic aortic regurgitation.
Yes.
But yeah, as I think we've talked about in some of our echo lectures, the color, what you see in color Doppler is sort of is key, right? And like you mentioned, the garbage in, garbage out, the image quality can often be tough in a lot of those qualitative and quantitative assessments of aortic regurgitation. And sort of you always want to ultimately fall back on what you see with color Doppler, because I don't know how many times you've been able to successfully accurately measure the PISA of aortic regurgitation, but it's not easy to do
Right.
frequently. So, but yeah, no, very good case. And we'll open it up to questions from the group. No, like, yeah, interesting case. And yeah, I mean, the only other thing I would say, and that's part of that EKG and the sort of presentation is exactly why acute aortic regurgitation makes people so sick, even more so possibly than acute mitral regurgitation, where in acute mitral regurgitation, it's pulmonary edema and the pink frothy sputum, just from acutely elevated pulmonary venous pressures. But in this case, it's acutely elevated LV diastolic pressures.
Right.
That can create this sort of massive amount of end diastolic, of subendocardial ischemia that you are showing there on the screen. That is just adding to the clinical picture. So, Dr. Abdu, question.
Good morning, Sonali. That was fantastic. Thank you for a comprehensive review. I think all of us need it. And I want to echo Dr. Williams. We see a lot of sick patients in the CICU. And for me personally, acute AI makes me very, very nervous. So that's coming from someone who deals with a lot of sick cardiogenic shock, but I find acute AI makes me very, very nervous and, difficult to manage and hemodynamically challenging. So, you kind of summarized it, and I love the EKG part, because that's also important and often missed and leads you in a path of the coronary disease, which is not the case. But very good case and very good review. It was more of a comment more than a question. So
thank you.
Obviously, a lot of our hemodynamic support devices we would normally use in someone in shock are not available to us in these patients as well, which sort of further complicates things. It's either, can this patient, acutely or quickly go to the OR and or cath lab for definitive therapy for their valve or not? And if the answer is no, because they're too sick or too high risk or whatever, it's a very, very difficult situation to manage, as this case showed. So
right.
Robbie, Stan Sherman.
Hey, Dr. Sherman.
Yeah, was there an autopsy? Was there something, did we ever find out about the coronaries with all the troponin elevations and all?
Right. Thank you for that question, Dr. Sherman. So unfortunately, the family actually declined the autopsy. So we did not get that done. And I think she did not have a left heart cath done overnight. When I spoke to the interventional attending, we were worried more about a global process. I know that she did have them previously. In talking to Dr. Devareddy, I think 4 months before this presentation, she had a CTA that showed that there was no high grade obstruction in the left main or in the LAD, but she did not have a repeat ischemic evaluation when she came in, when I saw her.
And so the decompensation was all felt to be the acute AI and not the chronic AS. Is that? Yes. And so all the changes were probably due to that. Great talk. Thank you.
Great. Thank you.
Sonali, that was a great talk. For a stable outpatient who, has an echo read with mild to moderate AI, what are the things that you recommend we look for besides LV changes as we do serial echoes for follow-up?
So I think that and Dr. Mehta, are you referring to a situation where the patient is asymptomatic, or?
Yeah, just you order like an outpatient echo and the read will say mild to moderate AI.
Okay, so I think that puts us, so I'm going to go back to this guideline slide because I feel like we see these patients in clinic a lot. So at that point, if they were asymptomatic and and if they had moderate, then if they required an other cardiac surgery, then I think it's class 2A to consider them for an aortic valve replacement. Other than that situation, if they're mild, then serial echoes, as you mentioned. And then to your point, I think we oftentimes see these, like I see these patients in my Grady clinic, they come in, they have severe or moderate to severe and they're asymptomatic. So in that case, you want to look at their LVEF. And if it's less than 55, then that would be an indication, class 1, to replace it, or if they needed to go for some other sort of surgery. And then their end systolic dimensions greater than 50, it's class 2A to replace it. But I would really also, bring them back frequently, evaluate for any development of symptoms as well. I hope that answered your question.
Yeah, that's great. Sometimes it's just difficult about asymptomatic versus symptomatic because sometimes people don't do as much and then they're not going to have symptoms. So
yes, yeah. So I think at that time, exercise testing, as long as they don't have, severe critical AS, can also give us, I think we had this talk that Dr. McDaniel gave us, and he mentioned that 70% of the time when, a cardiologist walks in the room and a patient's in the room, they walk away with completely different assessments on what the patient's symptoms are. So exercise testing can really help us maybe be more objective and accurate about that. So, yeah.
Dr. Wenger.
Okay, the lack of symptoms with physical activity is really not surprising because remember, as the heart rate increases, the regurgitation time decreases. So these patients have good activity tolerance for a long period of time. And if you wait for the development of symptoms, I think you have passed the sweet spot to intervene.
I was going to say that. I think you taught me that, Dr. Wenger, a long time ago with aortic regurgitation, that if you're waiting for symptoms and aortic regurgitation, you're going to be waiting a long, long time. That these are frequently patients that, particularly if it's, they have functional valve abnormalities, bicuspid valve or, prosthetic valve degeneration. These are frequently patients that the symptoms are a very late finding, and you'll frequently start to see LV enlargement, LV function decline, et cetera, well before symptoms present, particularly in a non-young patient.
Right. And so because aortic regurg is always kind of, it's not normal to have it. So that's why I was asking that question, that in a stable patient, if you see it, at what point do you just go ahead and ask for a TEE and go ahead and take care of it?
Right. Which is not an infrequent number of patients. So definitely an important point.
Okay. Well, again, Sonali, fantastic presentation. A lot to chew on there. Thank you everyone for tuning in for our first conference of the year, and we will see everybody next Friday morning.
Great. Thank you, everyone.
The preceding program is copyrighted by Emory University.